multi-sectoral HIV response in Zimbabwe. I would like to thank the organizers and Bangladesh for hosting this international conference. I think because of time constraints, I will be skipping some of my slides to try and present within the 10 minutes. Zimbabwe is a country located in Southern Africa with a population of 12 million people. HIV prevalence is currently around 15% for those aged between 15 and 49 years. Antenatal care surveillance HIV prevalence is about 13.5%. 5.5% of young people aged between 15 and 24 are HIV positive. And of the 1.6 million orphans and vulnerable children in the country, 62% are due to HIV and AIDS. HIV remains predominantly sexually driven in the country. The national HIV response in Zimbabwe is coordinated by what we call the National AIDS Council, which is under the guidance of the Minister of Health and Child Welfare. And the response is based on a strong commitment at policy and operational level to ensure that everyone plays a complementary role. The country's response is guided by global commitments which look at issues of halting and reversing the spread of HIV and also universal access to prevention, treatment, and care. The response in Zimbabwe is guided by a number of policies, but the major ones are the National AIDS Council Act, the HIV/AIDS policy, and the Zimbabwe National AIDS Strategic Plan. We also have other policies which are related to HIV and a number of strategic documents which support the response. The National AIDS Council was set up in 1999 by an Act of Parliament to mobilize and coordinate and also monitor multi-sectoral response to HIV and AIDS epidemic in accordance to the National HIV and AIDS policy in Zimbabwe. And through this act, the National AIDS Council is empowered to set up a coordinating structure that has representation from key stakeholders from national down to community level for a vigorous HIV/AIDS response. I want to highlight what we call the National AIDS Trust Fund. This is one of a global best practice in terms of HIV/AIDS prevention in the world. This is a fund which was set up by government, whereby 3% of taxable income from those who are employed in Zimbabwe is put into a fund which is managed by the National AIDS Council. Cumulative contributions to date is about $84 million US dollars. 50% of this fund is mainly used for HIV/AIDS treatment and care. 25% goes to program management. Prevention gets about 10%, and the other items there, 5% each. We have what we call the Zimbabwe National HIV and AIDS Strategic Plan, ZINASP, which is a multi-sectoral and decentralized framework developed to guide and inform implementation of the national response. The development of the plan is evidence-based and also results-based and is mainstreamed gender and human rights in its operational strategies. Through this strategy, Zimbabwe will strengthen its commitment to achieve zero new HIV infections, zero stigma and discrimination, and zero AIDS-related deaths. This is just to show the framework which we use in terms of the multi-sectoral approach in Zimbabwe. We have a private sector coordinating mechanism. We have people living with HIV and AIDS. We have the public sector, which is government. We have civil society, which includes NGOs, community-based organizations, and faith-based organizations. And through this framework, we also identify key populations, and then we provide a comprehensive program which looks at prevention, treatment, care, and support, and also issues of information and advocacy within the framework. The guiding principles in the response include equitable access to services, evidence-based planning and policy making, integrated service delivery, gender sensitivity and responsiveness, and the meaningful involvement of people living with HIV and other vulnerable and affected populations. Building on good practices from Zimbabwe and other countries, and the 3 1s principle, where we say we need one multi-sectoral action framework, one national coordinating authority, one monitoring and evaluation system, and also creating an enabling environment. In terms of our priorities in the response, we have 2 main priorities. One is to ensure equitable access to quality, cost-effective HIV prevention programs that are suited to the epidemic context, people's needs and rights to prevent HIV infection. The second priority is to ensure universal access to treatment, care, and support through more effective, ethical, affordable, and sustainable approaches to service delivery. In terms of the response, we want to ensure that we adhere to two overarching strategic approaches that will cut across the priority areas, programmatic strategies and interventions. These are the integration of HIV responses into existing systems and strategies, so that we do not use a vertical HIV program implementation approach. Then number two, to ensure that there's a strengthening of the systems, the health systems, the community systems, and also improve monitoring and evaluation. I'll go to the management and coordination of the national response. Management is through the decentralized coordinated structures, what we call the AIDS action committees, which are at provincial, district, ward, and village level. And these were established to provide an enabling environment and community advocates for HIV and AIDS. And there are various technical groups for specific HIV thematic areas. In addition, we have steering committees for maternal and child health, and also for the integration of sexual and reproductive health and HIV. The multi-sectoral coordination has been consolidated through umbrella coordinating structures for each specific sector. Community health systems have also been strengthened to improve service delivery and promote participation of people infected and affected by HIV. In terms of the financing of the response, like I've said, the AIDS levy has been a major source of funding for the response, and currently it's generating about $19 million US annually, which is used to support the HIV/AIDS response. Bilateral and multilateral partners have also provided funding, including the Global Fund. We have also funding from other partners for the integration of sexual reproductive health and HIV. Monitoring and evaluation is primarily based on a national framework which looks at the M&E plan and the national database on HIV and AIDS. And this is based on quarterly reporting by all districts and stakeholders. And data is used by all stakeholders to implement their programs. In terms of achievements, Zimbabwe is among the several countries with a mature HIV epidemic and showing a consistent decline in prevalence over the last decade. We have reduced prevalence by over 50% since 1999. About 85% of pregnant women attending ANC services are being tested for HIV, with over 60% of these HIV-positive women and 80% of the delivered babies receiving ARVs by 2010. Over 100 million male condoms and 5 million female condoms are being distributed annually since 2010. Coverage of HIV testing and counseling has increased from 35% to 64% in 2010. This is a graph just to show the decline in HIV prevalence over the last 10 years within Zimbabwe, which, as I've said, is more than 50% decline in HIV prevalence. In terms of other achievements, coverage for HIV treatment has increased from 5% to 60% in 2010 based on the CD350 criteria. 65% of people on treatment are females and 10% are children. HIV treatment sites have increased from 32 in 2006 to over 800 currently. Annual adult AIDS deaths have reduced from 123,000 in 2006 to 71,299 in 2010. The number of people receiving community-based care increased from 489,000 in 2008 to over 1 million currently. Lessons learned from the response in Zimbabwe indicate that local funding mechanisms, e.g. the AIDS levy, are critical for sustainability of national response to the epidemic. The National Strategic Plan, the ZNASP, provides an opportunity for diverse stakeholders to find their strategic niche based on their mandate and comparative advantage. Integration of sexual reproductive health and HIV is critical for provision of comprehensive and quality services. Civil society involvement is key in all community-based sexual reproductive health and HIV programs, and for empowerment of communities to own and deal with their health problems. Documentation of achievements is important in capturing impact of programs. In conclusion, Zimbabwe has adopted a multi-sectoral and integrated approach in the fight against HIV. The country will continue with this approach in order to ensure